high school grand rounds. Because of that, we had to change everything to the virtual format. Most of you have been doing it virtually anyway. So I still remember a couple of years ago when we had the visitor from the Mayo Clinic and it snowed and we had to cancel the grand rounds. The attendance was low because the university closed, and he was looking at where is the snow because it wasn't all that much compared to Minnesota. So anyway, today we have one of our faculty, Dr. Folsom, who will present to us on lipids. Folsom graduated from Walla Walla University in Washington, received her medical degree from Loma Linda University, did residency in internal medicine and pediatrics at South Carolina, and her fellowship in adult and pediatric endocrinology at IU. She joined us here in 2017, and she has been a stellar faculty. She's an extraordinarily efficient and effective clinician, astute. She's a great teacher and has a wonderful ability to bring complex clinical questions and boil them down to simple things that we can all understand and apply to our day-to-day clinical practice. So today she will be talking about lipid guidelines, a very timely topic given that this is a common problem and important in the current day. So I'll let Lisal take over.
Let me start sharing my screen here. All right, and give me a thumbs up, somebody, if you can see me and hear me.
Yes, we can see and hear you.
Perfect, excellent, success. Dr. Moshtagundam, thank you as always for that really lovely introduction. I have to bring tissues and wear waterproof mascara when you introduce me because you are always so very kind. I also wanted to thank everyone else who's joining us virtually today on this very cold, very rainy, very icy afternoon. And I'm delighted to be able to share a little bit about what I've been learning recently about lipid management in 2021. And the topic is choose your own adventure, ? Because up until I started preparing for this talk, I kind of felt that lipid management was a little bit of a choose your own adventure. And now I have a little bit more information that I hope we will be able to discuss today. Let me advance our screen here. Okay, I do not have any disclosures today. However, I will make a disclaimer, and that is that there is a lot of data and a lot of literature on lipid management, and we will not have time to discuss everything today. So do not consider this talk to be the be-all, end-all. There is much more to learn. What we will be talking about today is, first of all, whose job is lipid management? And then we will compare and contrast the main features of some of the recent lipid management guidelines that have been published. We will then look at the evidence for lipid targets in a variety of different patient populations. And then we're going to spend the majority of the time looking at the Endocrine Society clinical practice guideline that was recently published specifically for lipid management. And then finally, I think the most challenging part is to expand and develop the way that we manage lipids in our own practice. So why this topic? Lipids are pretty common in regards of management. Primary care doctors prescribe statins, cardiologists can do it, endocrinologists can do lipids, family doctors, everybody can do lipids. So why did I decide that as an endocrinologist, this is something that we needed to spend our grand rounds talking about? And the reason is because of this. Look at all of these lipid guidelines. We have lipid guidelines from the National Institutes of Health. We have lipid guidelines from the National Lipid Association. We have the American Cardiology Association. We have the American Heart Association. We have the Canadians joining the party. We have European guidelines. We have the American Diabetes Association. And so there are so many different guidelines, and the Endocrine Society just recently published their own set of guidelines back in 2020. And with all of this stuff out there, how do you know what to do? And that is particularly why I chose this topic, so we could hopefully figure out what to do. Before I can convince you, though, I think we need to talk about why we even care. Why do we even treat high cholesterol? And the reason is because heart disease is intimately related to elevated cholesterol values, and heart disease is the leading cause of death in the US. The literature shows that 1 in every 4 deaths is related to heart disease. So if you have 4 people in the room and they are dying, 1 of them is because of heart disease, and this should be preventable. There are both traditional and risk-enhancing features that contribute to someone's overall risk of heart disease. The traditional risk factors include age, sex, blood pressure, cholesterol, smoking, and diabetes. And then there are risk-enhancing features as well, such as having a family history, having metabolic syndrome or chronic kidney disease or other inflammatory conditions, the presence of early menopause or preeclampsia. Now, you'll notice that there's an asterisk next to race under traditional risk factors. If you're looking through the literature, having a race identity, anything other than Caucasian, is thought to be a risk factor for heart disease, but recently we have determined that race is not a risk factor. There are social determinants of health and socioeconomic differences that tend to be more common in different racial and ethnic groups, but having a race that is different from Caucasian does not in and of itself increase the risk. And so although this is still listed in the literature as a risk factor, I think it's really important that we know that it's not because of the genes, it's because of the situation. So what is risk? We have risk factors that are traditional, we have enhancing risk factors, but what really is risk? And ASCVD stands for atherosclerotic cardiovascular disease, and this is really what most of the guidelines are using to determine someone's risk for heart disease. We use the 10-year atherosclerotic cardiovascular disease risk and define it as the risk of having any event within 10 years. The categories are low, less than 5, borderline and intermediate, which are between 5 and 20%, and then a high risk would be 20% or higher, and this is again the risk of having any cardiovascular event in the next 10 years. And the way that risk is calculated is by using the 2018 Prevention Guidelines tool, Cardiovascular Risk Calculator, and you can use the website that I've listed below, but basically what you do is you plug in the patient's sex, their age, their race, for now, cholesterol values, whether or not they're on treatment for cholesterol or blood pressure, if they have any history of diabetes, if they smoke, aspirin use, you plug this all in, and the calculator will help to calculate their baseline 10-year risk. Now, before I tell you what to do with this number, we need to start back at the beginning. So I'm going to tell you the story of lipid guidelines and shed a little bit of light on why there are so many. So, once upon a time, we only had the NIH-sponsored guidelines, and the NIH published a set of guidelines about cholesterol management every few years starting in 1988 and most recently in 2013. And they were fine. They talked about cholesterol values and which cholesterol values needed to be treated and how to treat them and when to treat them and who should treat them. But then, in 2013, some data came to light that the American Heart Association and additional cardiologists incorporated into their own clinical practice, and they determined that the lipid guidelines published by the NIH were not sufficient, and they published their own. And so now we had the question, do we follow what the NIH says, or do we follow what the cardiologists say? And then the National Lipid Association got on board and published their own set of guidelines in 2015. And then in 2016, Canada joined the party and published their own set of guidelines. And then in 2017, the endocrinologists got on board and we published our own set of guidelines for clinical endocrinologists. And then Europe came along and in 2019 published their own set of guidelines. And then the Endocrine Society published some guidelines specifically related to cardiovascular disease in diabetes and patients at metabolic risk. And then the American Diabetes Association published their own lipid management guidelines in 2020. And then finally, the Endocrine Society said specifically we would like to address lipid management in patients with endocrine disorders. And so we have 9 different sets of guidelines from which we can choose, and this can be very confusing for clinicians who are just trying to do the right thing for our patients. So I'm not going to go over all 9 because we do not have time, but I did want to touch on some salient features comparing and contrasting. So where the guidelines are the same, all 9 of these say we should look at a patient's risk and we should base their treatment regimen on how high of a risk they are for a cardiovascular event. They also agree that patients who are at high risk should be treated if they have dyslipidemia. We all agree that having a high HDL cholesterol is not a risk factor and indeed may be quite protective against cardiovascular disease. And they all agree that for first-line therapy, a statin is a really good medication to use. Lower numbers in regards to total cholesterol and LDL are typically better than higher numbers. And they all recommend that patients should do healthy things to improve their cholesterol and their cardiovascular risk. I think we can all agree on these. But there are some really important differences in the guidelines, the first of which is definition of risk group. Who is at risk, and how do we figure that out? And then primary treatment goals. What are we looking at as far as our outcomes? How do we determine if our treatment is working? And some of the guidelines prefer to look at the LDL target. Others say non-HDL cholesterol, and still others target the ApoB level. And then some of the guidelines say we should treat to target. We should treat to an absolute number, an LDL under 100 or under 70 or under 50. And other guidelines say we should shoot for a % reduction. We should try to decrease the LDL cholesterol by 50%. Another difference is statin intensity recommendations. When do we use a moderate versus a high intensity statin, and does it matter? So we have guidelines, we have recommendations, we have standards of care, and we have many different organizations who are publishing these, and it seems like a choose your own adventure book, right? Maybe we have a patient and we have an idea of what we want to do. So instead of using the evidence and following one set of guidelines, maybe we can pick and choose, and we can find a set of guidelines that supports what we want or what the patient wants. And I don't want to practice medicine that way. I want to be the best doctor that I can be for my patients and recommend the right thing for them. And so I hope that instead of choosing our own adventure, we can really dive into the evidence and make those right decisions for our patients. Speaking of, let's talk about a few patients that we are probably going to see in our practice. The first of which is a 17-year-old young lady who has type 1 diabetes that was diagnosed when she was 6. She's currently managed with Control-IQ, which is an integrated insulin pump and continuous glucose monitor system. Her most recent A1C was 8.2%, and we've got a fasting lipid profile which shows a total cholesterol of 192, triglycerides of 111, an HDL cholesterol of 58, and LDL of 122. This is a really typical case that we might see in our office. And we need to think about whether we need to be concerned about her cholesterol and if we need to do anything about it. Patient number 2, an 82-year-old man diagnosed with primary hypothyroidism at age 56 years old. And this gentleman, being 82 years old, has had a heart attack in the past and underwent a cardiac bypass surgery at age 64, and he's currently taking a statin. His hypothyroidism is managed with levothyroxine, and his most recent TSH was at target at 3.4. And we obtained a fasting lipid profile which revealed a total cholesterol of 165, triglycerides 132, HDL 42, and LDL 99. What are some things we should think about in managing this patient? And patient number 3 is a 22-year-old transgender young man who has no known medical diagnoses. He's pretty healthy, and he's currently taking testosterone 40 milligrams subcutaneously every week. His fasting lipid profile shows a total cholesterol of 146, triglycerides of 602, HDL 53, and unable to calculate the LDL based on his elevated triglyceride level. What should we think about in regards to the further evaluation and management of this patient? And all three of these patients are atypical because they're not between the ages of 40 and 75, which is what our risk calculator calculates. And so are we out in the wilderness? Do we have any guidelines or recommendations to help us? Let's discuss. Here are the Endocrine Society Clinical Practice Guidelines, fresh off the presses. We joined the Guidelines Club in 2020, and what the purpose of these guidelines is to provide an approach to the assessment and treatment of dyslipidemia, specifically for patients with endocrine diseases that we all will most likely see in our practice. And the goal that they say of publishing these guidelines specifically was both to prevent cardiovascular events and triglyceride-induced pancreatitis, which is something that we will often get consulted on in the hospital. And the guidelines includes a review of whether treating the endocrine disorder improves the dyslipidemia, regardless of statin use, and whether treatment of endocrine disorders also improves cardiovascular outcomes. So it adds to the literature in this way. So what do the guidelines say? What actually are we looking at? And what they recommend is that all adults with endocrine disorders, people we see in our offices, should have a cardiovascular risk assessment looking at the traditional risk factors and also calculating the 10-year atherosclerotic cardiovascular disease risk like we discussed earlier. They also recommend checking a lipid panel in all patients with endocrine disorders. And then we calculate the 10-year risk. This is easy, right? We plug it into the calculator and we get the risk. Is it low? Is it borderline? Is it intermediate? Or is it high? High risk and low risk are easy. If someone's high risk, they don't get a statin. They do get a statin. If someone is low risk, they do not get a statin. But the borderline and intermediate risk categories are a little bit cagier. If you have a 5 to 19.9% risk of cardiovascular disease, how do we decide if someone should be treated with a statin or not? And this is where the guidelines recommend obtaining a coronary artery calcium score, which is done by using a very low radiation, very quick CT scan of the coronary arteries and documenting how much calcification there is. And this has been associated with cardiovascular risk. So the way that this works, looking here at the x-axis, you can see that LDL values, and these are in millimoles per liter, the coronary artery calcium score is on the right, and the rate of cardiovascular disease is on the left. And the way to break this down is looking at yellow, green, and red. Yellow is people who have a coronary artery calcium score that is 0. Red is a coronary artery calcium score greater than or equal 100. And this correlates specifically with cardiovascular risk. And so if you can combine the coronary artery calcium score with your risk assessment, this helps to figure out your recommendations regarding statin use. So putting this in another way, we look at the borderline and the intermediate risk categories. And if we look at the risk alone, recommend statin. Not particularly helpful. But if we look at the cardiovascular risk assessment, you can see that if the cardiovascular risk assessment and the calcium score are less than 0, then we don't recommend a statin. But if we look at the risk assessment and add a calcium score and it's greater than 0, then they do recommend a statin. And so getting this coronary artery calcium score can reclassify a patient either to low risk or high risk. So it's another piece of the puzzle that we can use to calculate our risk. The guidelines mention lipoprotein A, and this is not something that I will typically measure in my clinical practice, but I wanted to address it, and it's specifically an LDL-like particle that has ApoA attached to it. And the levels are determined by genotype, meaning that it's not influenced by the things that we eat or our environment. You're born with whatever ApoA level you have. Now, higher level has been associated with increased risk, but why do we even care if we're born with our level and it doesn't change? And the reason for that is that it's helpful to look at familial risk. We can't really lower the level because it's determined by genotype, but if someone is found to have a very high level, then we might bump them up in risk category and recommend treatment when otherwise we might not have based on their risk assessment. So now we're going to move on to some very specific endocrine diagnoses that are addressed in these guidelines. And the first is hypertriglyceridemia, which is defined as a fasting triglyceride level greater than 500. The guidelines recommend first of all using lifestyle modifications to help improve the triglyceride level, and then you can also add pharmacologic treatments such as statins, fibrates, and omega-3 fatty acids. If someone has a fasting triglyceride level greater than 1,000, this significantly increases their risk for pancreatitis, and medicines don't work very well in this situation. And so really, if someone has a fasting triglyceride greater than 100, they have got to change their lifestyle. They have got to significantly decrease their intake of foods known to affect cholesterol, things such as simple sugars, processed food, alcohol, fried foods. And you can use medicines, but really they're not going to work alone. This really has to be a lifestyle thing. And that's something that the guidelines emphasize. Now, there is one medicine that may be effective called Vulnerasourcin. It's a fantastic medication. It's an antisense oligonucleotide to ApoC3, and before you fall asleep, this is how it works. The medicine goes into the cell, traverses the nuclear membrane, and then it binds to the mRNA where ApoC3 is produced, which plays a role in the production of triglycerides in the liver. What happens is it prevents this formation of triglycerides, so you literally, it's kind of like a statin for triglycerides. It's amazing, it's fantastic, it works really, really well, but it's not approved in the US. It is only approved in Europe. But before we get too jealous of Europe, I just wanted to highlight a few things that are approved in the US that are not approved in Europe. First of which is Mountain Dew. You cannot buy Mountain Dew in Europe because it contains brominated vegetable oil, which is thought to be unhealthy, and so you cannot have Mountain Dew in the US or in Europe, whereas you can have it here. You also cannot buy many different types of beauty products, including nail polish in the UK and the EU, because they contain formaldehyde. So they have cholesterol and triglyceride treatment. We have Mountain Dew and nail polish. I'll let you decide who has the better end of the deal. Other specific factors related to hypertriglyceridemia. If an individual is on a statin, has a triglyceride level over 150, and has either known cardiovascular disease, 2 risk factors for cardiovascular disease, or type 2 diabetes, then it is recommended that you add eicosapentaenoic acid to their regimen. The recommended treatment dose is 4 grams per day, and this is a specific omega-3 fatty acid. And if you can't, consider using a fibrate instead. And in this situation, what the evidence shows is that actually the level of triglyceride is not as important as being on treatment, specifically in regards for cardiovascular disease prevention. Another endocrine diagnosis that is often associated with hypertriglyceridemia, but even more so with LDL and cardiovascular disease, is type 2 diabetes. The UK prospective diabetes study showed that LDL cholesterol was the strongest predictor for cardiovascular events in type 2 diabetes. And the risk for having a cardiovascular event is 2 to 4 times higher in someone with type 2 diabetes compared to someone who does not have this diagnosis. The really scary thing is not only that they are higher at risk, but they're at risk earlier, almost 15 years earlier. So if a person with type 2 diabetes was going to have their first heart attack at age, or a person without was going to have their first heart attack at age 70, it's going to happen at age 55 instead. So this is a huge deal and something we really need to emphasize to our patients. The study also found that the female sex was less protective. We typically think of women as being at lower risk for cardiovascular disease, but this does not seem to be the case in type 2 diabetes. And so with statins, we can actually reduce these risks by about 22 to 35 or 37%. And this is true regardless of what the LDL level or the history of cardiovascular disease. And this is where the American Heart Association began mentioning treat to a percentage rather than treat to target because of this data. It doesn't matter what the LDL level is, it matters that you're on a statin. Although a meta-analysis was published that showed that for every 40 milligrams per deciliter of LDL reduction, there was a 20% decrease in cardiovascular events and a 10% decrease in mortality. So lower is better, according to this meta-analysis. Another meta-analysis looking specifically of 26 statin trials showed that the greater the LDL reduction, the greater the cardiovascular benefit. For every 39 milligrams per deciliter in LDL decrease, there was a 22% relative risk reduction in major cardiovascular events. So again, lower is better. And this was shown in the Prove It to Me 22 trial, where they were able to look at subgroups, and they were able to show an improvement both in cardiovascular disease risk and mortality in every subgroup, going down to under 40 for LDL levels. So rather than treating to a target, just treat to very, very low, is what this seems to suggest. So based on this evidence, what do the guidelines recommend? And what they say is that if somebody has diabetes and risk factors, they should absolutely begin some lifestyle modifications. We should shoot for an LDL at least under 70. And if someone has known cardiovascular disease or at high risk, they should be on a high-intensity statin. They also recommend not using statins in pregnancy because they are teratogenic to a fetus. And they suggest that if someone is older, over 75 years of age, it's important to have the conversation about whether a statin is going to be helpful for them, specifically based on quality of life and life expectancy. If your 75-year-old patient is planning to live to be 100, a statin would probably be a really good thing. But if they're kind of getting the dwindles and maybe don't have a good amount of years left, is adding another medicine to their regimen going to be more burden than it is benefit? So have that conversation. You can also use ezetimibe to lower LDL, and they also recommend using PCSK9 inhibitors, which will further decrease the LDL if we're not getting under 70 with our statin use alone. There are some specific conditions that are related to type 2 diabetes, and kidney disease is one. We know that in kidney disease specifically, cardiovascular disease is the leading cause of death, similar to in type 2 diabetes. And the risk is less if you can decrease LDL in chronic kidney disease. Now, this is not as big of an effect if diabetes has caused the kidney disease, but it still does improve the risk. If someone has, however, developed end-stage renal disease and is already on dialysis, then there's no benefit using a statin and no benefit in lowering the LDL further. You've got to get on this early. The guidelines recommend that in somebody who has type 2 diabetes and chronic kidney disease, regardless of age, regardless of other risk factors, a statin be prescribed, but not if someone's already on dialysis. And then another complication that we often see in type 2 diabetes is related to the eyes. The field study was a really interesting study that wanted to look at the risk of cardiovascular disease event reduction, specifically with the use of fibrates for cholesterol treatment. They had nearly 10,000 participants who had type 2 diabetes, and they did not find any significant cardiovascular risk reduction. So, helpful to know what not to do, I suppose. But when they looked at these groups, you guys, and this is the crazy thing, is they found that although they did not decrease their cardiovascular disease risk, they significantly decreased the incidence of retinopathy in this patient group. So you can decrease the onset of eye disease by using a fibrate. Now, was this just a fluke? And indeed, no, because the Accord trial actually showed the same thing. In people who already had retinopathy, those on a fibrate had delayed progression of their retinopathy. So, the guidelines say that if you have type 2 diabetes and retinopathy, please add a fibrate to your statin to hopefully prevent the progression of retinopathy. Crazy. Speaking of crazy, type 1 diabetes. This is something that we also see very frequently in our clinic. And the question is always, is type 1 the same as type 2? And we know that it isn't, and this comes up in the COVID literature as well. Type 2 diabetes is listed as a CDC risk factor, and those individuals are in the sooner vaccination group than type 1 diabetes. But is the risk for heart disease different between the two groups? The heart protection study showed that the risk reduction in treating hyperlipidemia was the same in type 1 versus type 2 diabetes. And a Swedish study looking at just over 24,000 individuals who had type 1 diabetes showed that statin use reduced the risk of death, cardiovascular disease events, and strokes, specifically in individuals with type 1 diabetes. So the risk is the same, and statins can be helpful. But what about in kids? There's a lot of question about dyslipidemia in individuals who are under the age of 18. What do we do with that? In the type 1 diabetes exchange, they were able to look at participants between the ages of 10 and 17, and they found that an LDL over 100 milligrams per deciliter was more likely to have cardiovascular disease risk factors associated with it. Now, 10 and 13 and 17-year-old kids are not going to have a heart attack, right? We know this. It's super uncommon. But if we look at those risk factors, it was associated with a higher LDL level. And we know that risk factors are associated with cardiovascular disease. And so this is, I think, a really useful piece to the puzzle. Pittsburgh Epidemiology of Diabetes Complications study was able to look at participants a little bit older, between the ages of 28 and 38 years old with type 1 diabetes, and they found that cardiovascular disease rates increased every year after the diagnosis of diabetes. So even in this young age group, people under the age of 40, the longer they had diabetes, the more at risk they were for a cardiovascular event. And cardiovascular disease accounts for 40% of death in people who have type 1 diabetes and have had it for over 20 years. Now, thinking back to our very first few slides, the risk for cardiovascular disease and death being a contributor was 1 in 4. That's 25%. But in type 1 diabetes, it's 40%, so significantly increased. Some specific conditions that we often kind of don't think about in type 1 diabetes are obesity and metabolic syndrome. We know that in the US, the obesity epidemic is rampant. And regardless of whether you have obesity or not, you're still at risk for type 1 diabetes if you're a child. And what we kind of typically say is that if you treat the hyperglycemia, you improve the dyslipidemia, which is one of the reasons that we don't typically get a lipid panel in new onset individuals, because it's going to be bad and it's going to get better when we treat the hyperglycemia. Or is it? Some data from the Search for Diabetes in Youth study showed that it's not enough. Your dyslipidemia may get a little bit better when hyperglycemia improves, but typically does not return to the normal range. This is shown also in the DCCT EDICT trial looking at the legacy effect in type 1 diabetes, which suggested that individuals who had optimal or improved glycemic control early on in their diagnosis tended to have fewer complications later on in life, which is fantastic. But when they looked at those individuals further out from the onset of the study, they found that those who had gained excessive weight actually had less of a legacy benefit than those who had not. When they looked at specific predictors, they found that an A1C value and then triglycerides and LDL were actually the best predictors for cardiovascular disease risk. And the group who had the most weight gain also had the most cardiovascular disease events. And so assessing for and treating obesity and metabolic syndrome in our patients who have type 1 diabetes seems to be really important. So what are the recommendations specifically for this patient group? If a person has type 1 diabetes and they are either 40 years or older, they should be on a statin. Or if they've had diabetes for longer than 20 years, they should be on a statin. Or if they have any microvascular complications, they should be on a statin. Or if they have any kidney disease other than end stage, they should be on a statin. Or if they have obesity or high triglycerides or low HDL consistent with metabolic syndrome, they should be on a statin. And I think these are very interesting guideline recommendations and very specific, and something that I will be honest, I was not doing prior to preparing for this talk. They also recommend that if someone's LDL is greater than 70, regardless of these other things, these other risk factors, consider statin. Definitely things to think about. I want wanted to focus on a few other endocrine conditions that we often see frequently in our clinical practice. The first of which is obesity, which is defined either as a BMI greater than or equal to 30 kilograms per meter squared, or by waist circumference. And in gentlemen, that's defined as either greater than or equal to 40 inches, or in East or South Asian men who tend to be smaller, greater than or equal to 35 inches. And women, greater than or equal to 35, or East and South Asian women, greater than or equal to 31.5 inches. We know that obesity is associated with metabolic syndrome, which, thinking back to our risk factor slide, is a risk-enhancing factor for cardiovascular disease. What the data shows is that if someone who has obesity is able to decrease their body weight by over 5%, they will also decrease their triglycerides and their LDL levels and increase their HDL. The effect, granted, is greater on triglycerides than it is on the cholesterol values. And a meta-analysis of 73 randomized controlled trials containing over 32,000 people showed that for every kilogram of weight loss, their triglycerides decreased by 4, their LDL decreased by 1.3, and the HDL increased by 0.5. Now, these seem like kind of weeny numbers, but if you think about it, if someone's able to lose 10 kilograms of body weight, or just over 22 pounds or so, they could have a 40-point decrease in their triglycerides, a 13-point decrease in LDL, and even a 5-point increase in HDL, which is not insignificant. So based on this, what the guidelines recommend is that in an individual that we see who has obesity, we should assess them for metabolic syndrome, also assess their 10-year cardiovascular disease risk. Lifestyle modifications should be our primary treatment. And if they're on pharmacologic therapy for weight loss, keep an eye on the lipid profile because, as we've seen, it can change over time. And if they are losing weight, wait until their weight is stable before reassessing lipids because that could significantly change our recommendations and management. Another really common thing that we see in clinical practice is thyroid dysfunction, and this can have an intimate relationship on our lipid panel. In hypothyroidism, we actually have reduced number of LDL receptors and reduced lipoprotein lipase activity. And this leads to an increase in total cholesterol, triglycerides, LDL, and in ApoB. So you can imagine then in the hyperthyroidism, we'll have an increased number of LDL receptors and also faster hepatic clearance of many of our cholesterol values. So in hyperthyroidism, we see decreased total cholesterol and LDL, which seems really good, but we treat these things. We treat hypothyroidism and we treat hyperthyroidism. So what happens when we treat? Well, this is what happens. If a patient comes to us and they are in a hyperthyroid state and we start either anti-thyroid medication, radioactive iodine ablation, or remove the thyroid gland, you have a significant increase in both total cholesterol and LDL. So we have iatrogenic dyslipidemia in these patients. And in hypothyroidism, the inverse happens. So we treat the hypothyroid state, we increase the LDL receptors, and we increase the lipoprotein lipase activity, and we decrease the total cholesterol and LDL, again, significantly. Now, something interesting that I was not aware of before preparing for this talk was that in subclinical hypothyroidism, if an individual happens to be treated with levothyroxine, you also get a statistically significant decrease in both total cholesterol and LDL. Okay, so what do the guidelines recommend? They recommend that if you have someone with dyslipidemia, before starting a statin, evaluate for hypothyroidism. And the reason for this is that you want to correct hypothyroidism before just throwing a statin into the mix. Because if you can correct that abnormal physiology, you don't need to add a statin. They also recommend that in hyperthyroidism, we monitor the lipid panel once treatment has begun to evaluate for dyslipidemia that may be present after that wasn't present before. And this is the second mind-blowing thing. The first was the retinopathy and fibrate connection. This is the second. So in subclinical hypothyroidism, defined as no symptoms but a TSH that's elevated between 4.5 and 10, and dyslipidemia, consider levothyroxine treatment. So typically if someone's feeling fine, I don't treat subclinical hypothyroidism with levothyroxine, but what they suggest is that if you can improve that dyslipidemia, which again is a risk factor for cardiovascular disease, by prescribing levothyroxine, even if they're feeling fine, it can help prevent cardiovascular disease in patients with subclinical hypothyroidism. Okay, another endocrine condition that we need to talk about. Glucocorticoids, our most favorite and least favorite adrenal gland hormone. The way that glucocorticoids affect our lipid panel is by increasing total cholesterol, triglycerides, and LDL, thinking back very similar to the effects of metabolic syndrome on the lipid profile. They also increase hepatic synthesis of VLDL. And as you can imagine, in Cushing syndrome, where we have a plethora of glucocorticoid production, the prevalence of dyslipidemia is pretty high, quoted between 38% and 71%, depending on which study you read. So then, what do they recommend? What do the guidelines recommend, knowing the effects of glucocorticoids on our lipid profile? They say that if we have a patient with Cushing syndrome, assess for dyslipidemia. Now, if the person has persistent Cushing syndrome, they haven't been treated, or they can't be treated, or they can't be cured, treat the dyslipidemia with a statin. However, if someone has cured Cushing syndrome, their risk seems to be the same as in the general population, and we should respond as so. So assess their atherosclerotic cardiovascular disease risk just like we would for any other person, and treat as you would based on the guidelines. And then if someone is receiving chronic glucocorticoid therapy for any reason, whether it's CAH or whether it's a chronic inflammatory condition such as rheumatoid arthritis, if their glucocorticoid prescription is above physiologic levels, assess for and treat dyslipidemia, similar to how you would with Cushing syndrome. Another hormone that we often talk about in clinic is growth hormone. Growth hormone also has effects on our lipid profile by increasing the expression of LDL receptors. So you're able to bind more LDL if you have growth hormone present. It also reduces the expression of PCSK9, which allows your LDL receptors to hang out a little bit longer. So we have more LDL receptors, and they remain longer in the body. So in growth hormone deficiency, we can anticipate what would happen. Because we have lower expression of LDL receptors and we have more rapid breakdown, we're going to have higher total cholesterol and LDL values. There's also this decrease in lean body mass and increase in visceral adiposity, which increases the chance of metabolic syndrome. If someone has growth hormone deficiency that is associated with pan-hypo-pit, this is what we know about the risk for cardiovascular disease. We know that they're at an increased risk for premature mortality and specifically cardiovascular-related morbidity and mortality. The life expectancy, even with treatment, is lower than individuals who do not have pan-hypo-pit. And even if you treat with growth hormone, their cardiovascular risk is higher compared to someone who does not have pan-hypo-pit and growth hormone deficiency. The unfortunate thing with all this is that even if you prescribe a statin, there's no evidence that the therapy itself is going to lower the cardiovascular disease risk. So we know the risk is higher, but statins don't seem to decrease it. Now, the opposite of growth hormone deficiency we know is acromegaly, and excess growth hormone is also associated with things that increase our morbidity and mortality by 2 to 3-fold. Specifically related to cardiovascular disease. Things such as hypertrophic cardiomyopathy, systolic and diastolic dysfunction, arrhythmias, valvular disease, and atherosclerosis are all more common in growth hormone excess, as well as insulin resistance and glucose intolerance, which can lead to metabolic syndrome. Lipid abnormalities are seen, but not as much as in growth hormone deficiency, and the most common is elevated triglycerides. So the guidelines recommend that if someone is diagnosed with a growth hormone abnormality, either too much or not enough, obtain a lipid profile at diagnosis, and if they have growth hormone deficiency associated with pan-hypo-pit, assess for and treat all the risk factors that they have. They also recommend not using growth hormone solely to treat dyslipidemia and growth hormone deficiency. Use a statin. And in acromegaly, measure the lipid profile before and after treatment so you can know what effect your treatment has had on the lipids specifically. Polycystic ovarian syndrome is mentioned in the guidelines, and there is some data showing that dyslipidemia is present in up to 70% of women with this diagnosis. Specifically, elevated triglycerides in LDL and low HDL. And we find that this is actually milder in women who ovulate and women who are defined as lean PCOS. But even so, an LDL value over 100 is present in between 24 to 40% of patients with PCOS, irrespective of how much they weigh. We don't have any long-term data that is prospective looking at the cardiovascular disease risk. So we have LDL numbers, we have HDL, we have triglycerides, we don't have the cardiovascular disease risk. So the data is not as robust in this condition. And we also know that in PCOS, there's a minimal effect of lifestyle changes on the lipid profile specifically. We know that it improves metabolic syndrome in general. We know that it improves quality of life. We know that weight loss, but the lipid profile is not as robust in regards to the data. And so what the guidelines recommend is looking at the lipid panel to help assess their risk. And don't use lipid lowering therapy to treat PCOS as a primary reason. Looking at the effects of hormones on our lipid panel, we'll start first with hormone replacement in menopausal women. We know that estrogen has a role in how cholesterol is metabolized in the liver. We know that it improves metabolism in the liver, and so in menopause, that lack of estrogen causes the lipid metabolism to shift towards an increased LDL and decreased HDL state. We know that women treated with estrogen in a menopausal state do have increases in HDL and decreases in LDL, but we also know that there are some cardiovascular risks associated with menopause treatment. Now, most women who have a uterus who are on hormone replacement therapy in menopause take not only estrogen but progesterone. And progesterone decreases the HDL, and so the net effect is really not incredibly significant. In women who begin hormone replacement therapy for menopause before the age of 60, their cardiovascular disease risk seems to be decreased with treatment. But in women who start treatment over the age of 60 or are 10 years after the onset of menopause, their cardiovascular disease risk is increased. So a little bit of conflicting information. Now in men, we know that men with hypogonadism do have an increased cardiovascular disease risk. But we don't really know about the effects of hypogonadism specifically on the lipid profile. And men who are started on replacement doses don't really seem to have any change in their lipid profile. However, in men who are using high doses of testosterone for bodybuilding effects, for example, their HDL decreases by over 50%, and their LDL increases by over 50%. So some significant effects of testosterone use on the lipid profile if it's used at supraphysiologic doses. And so based on all this, what the guidelines recommend is that in someone who has hypogonadism, whether it's menopausal or a man with low testosterone, look at the risk and treat based on the risk. If they have dyslipidemia, treat with a statin rather than sex hormones. But do use hormone replacement therapy to treat symptoms of menopause and hypogonadism as would be otherwise clinically indicated. And if you find a man who has very, very low HDL, be suspicious and assess for the use of exogenous testosterone use, because there are very few things that can cause that clinical picture. So something that's intimately related to sex hormone use is the use of gender-affirming hormone therapy in individuals who identify as transgender. We don't have a lot of data on lipid changes with gender-affirming hormone therapy. There are some studies that suggest that with testosterone use in transgender men will have an increased triglyceride and LDL and decreased HDL, and there are some studies that suggest potentially increased triglycerides with oral, but not transdermal estrogen use in transgender women. However, all of the studies are relatively low power and the confidence intervals are pretty wide. So I think we need a little bit more information in regards to this patient population specifically. And most importantly, there's no data that evaluates either cardiovascular disease or cardiovascular disease risk. So what do we recommend based on the lack of data? And what the guidelines suggest is, just as you would for any person regardless of their gender identity, use what we have to assess their cardiovascular disease risk. What are their traditional risk factors? What are their risk enhancing features? And what is their 10-year atherosclerotic cardiovascular disease risk? And we really don't know whether to use the sex assigned at birth or the gender identity for risk calculation. So it is a conversation to have with our patients. A little bit about lifestyle modifications and non-pharmacologic treatments. So the guidelines do recommend some specific lifestyle things we should recommend to all of our patients, and the first of which is nutrition. They recommend that we emphasize vegetables, fruits, whole grains, legumes, nuts, seeds, low-fat dairy, and lean meats, and we recommend that people stay away from saturated fat, trans fat, sodium, processed foods, simple sugars, and alcohol, all very reasonable things. And they also recommend exercise. So you can either do moderate intensity exercise, 100 to 300 minutes per week, or if you want to save time, you can exercise really hard for 70 to 150 minutes per week. Either is good. They also recommend a degree of resistance training at least twice per week, and in our patients who are a little bit older, they recommend adding balance training to help with core strength and to prevent falls. Now, exercise recommendation is going to decrease the LDL by between 2.5 to 6 milligrams per deciliter. So not a huge decrease, but still significant and helpful and not harmful. And then dietary fiber is something that's mentioned a little bit in the guidelines, but also in the existing medical literature. There's no universally agreed upon definition for dietary fiber, but what the definitions that are out there do agree on is that it's something we eat and it's resistant to digestion or absorption in our GI system. The way that dietary fiber works theoretically to decrease cholesterol values is that it increases our rate of bile acid excretion, as demonstrated in this picture, where our bile acids stay in the intestine and bind to that soluble fiber to prevent reabsorption, which is going to prevent cholesterol production. Soluble dietary fiber is really the way you want to go, and this is things such as whole grains, legumes, beans, seeds, nuts, and some fruits and vegetables. And this is the type of fiber that actually binds those bile acids to decrease cholesterol. There's also insoluble dietary fiber, which includes some whole wheat flours, brans, brown rice, nuts, beans, and other vegetables. And this is the type of fiber that helps to decrease the risk of constipation and maintain regularity. But this type of fiber is not going to have as an important effect on the cholesterol panel. So, eating solitary fiber can reduce your total and LDL cholesterol by 5 to 10%, so a very good adjunct to additional treatments. There's not a lot of changes in LDL or triglyceride level, but again, it's not a bad thing, certainly a good thing, and always encourage fruits and vegetables. So, hopefully we've completed most of these objectives, but I wanted to spend a little bit of time still talking about how to manage our own patients. And this is going to bring us back to those 3 patients we discussed at the beginning. The young lady with type 1 diabetes, has had it for 11 years. Her total cholesterol is 192, the triglycerides are okay, but the LDL is 122. And based on the recommendations, an LDL over 100 is a risk factor, and ideally we would want it to be under 70. So in this situation, even though she's 17, consider statin therapy. Now she's 17, and so it's also going to be really important to talk about pregnancy prevention, reliable contraception, birth defects, and you know, some long-term things to think about as well. But based on the guidelines, her LDL puts her at risk for this early onset of cardiovascular disease. Our second patient, the 82-year-old gentleman with hypothyroidism, known cardiovascular disease, on a statin, on levothyroxine, with an LDL of 99. Again, he has hypothyroidism. It is treated. His LDL is 99, and his risk factor for cardiovascular disease is very high because of his age, because of his cardiovascular history. And so in this gentleman, we have to have that conversation. We have to say, are you planning to live to be 100? If so, a statin would probably be the right move for him. And if he's already on a statin, as he is, either increasing the intensity or adding additional lipid-lowering therapies like ezetimibe or PCSK9 inhibitors. And finally, our last patient, the 22-year-old transgender man who's on testosterone and his triglycerides are 602. Based on this, he is at risk for pancreatitis and potentially an earlier onset of cardiovascular disease. And so really having that conversation about lifestyle modifications, fruits and vegetables and whole grains and fiber, and really getting that total cholesterol down, or excuse me, the triglycerides down, is going to be our first step in management, and then reassessing where that lipid panel is. So, lipids and the endocrinologist. Hopefully I've convinced you, as I have been convinced, that lipids are absolutely our thing, right? Lipids are intimately affected by many of the conditions that we frequently treat in our office. Type 2 diabetes, type 1 diabetes, triglyceride-induced pancreatitis, thyroid disease, Cushing's, growth hormone abnormalities, menopause, hypogonadism, and transgender hormone care. So yes, it is our thing. And we have a lot of guidelines to choose from, but I think the data is there to support treating dyslipidemia in these conditions. And the last thing I think it's also really important to remember is that although the data is there, these are guidelines, right? They are not rules, they are not laws. And one of the beautiful things about the practice of medicine is that we get to take all the evidence into consideration. We get to incorporate it into our own clinical practice, and we get to make decisions for each patient as an individual. And so using the guidelines as guidelines for our clinical practice, but making sure that we truly are practicing the art of medicine and giving each patient the individual attention and care that they deserve to both prevent cardiovascular disease and overall improve and enhance their quality of life. With that, I wanted to thank you so much for your attention. Thank you for joining me virtually today. Our event code is below, and I would be more than happy to take any questions that anyone may have.
Hey, I have some questions on the chat.
Ooh, yes. Let me stop sharing, and I will open up the chat. Okay. Hi, Alan. Okay. Question number 1. Does dyslipidemia have any genetic predisposition in type 2 diabetes? If yes, which single nucleotide polymorphisms are associated with dyslipidemia? Also, have you come across adverse effects from long-term statin intake? Really great question. I am not a molecular geneticist, and I will be very honest with you, which I think is important to do in medicine, and tell you that I do not know which SNPs are associated with dyslipidemia in regards to the genetic predisposition in type 2 diabetes. So that is something that I will need to find out. In regards to your second question, adverse effects from long-term statin intake, no. But there is a slightly increased incidence of type 2 diabetes onset in statin use. But what we found is that the risk for diabetes onset is significantly lower than the risk for cardiovascular disease. And so if you want to make somebody live longer, a statin is the way to do it. We can treat diabetes, but preventing cardiovascular disease is the way to go. Second question, does red wine increase HDL level? So there are some substances in red wine that are thought to be associated with increased HDL level. A while back people were saying drink a glass of red wine every day. You can also get this effect with grapes, or exercise actually will increase HDL even more so than red wine. So again, it's not going to hurt you unless you drink too much red wine too much of the time. All right, I think that's the last chat question. Are there any other questions that anyone has?
Since these guidelines, the newer ones, are taking the statin therapy to lower ages where I don't know if they have enough evidence in terms of long-term cardiovascular event rates, the question is the safety in women in terms of pregnancy, and what would you recommend in a young woman with like your patient who is 17 and has a high LDL?
Yeah, absolutely. Really great question. And that's incredibly important. We know that women of childbearing age, and I mean, truly, that's anywhere from the onset of puberty until the onset of menopause. So a woman is of childbearing age much more of her life than she isn't. And so the question is, what are the risks and benefits of statin use? What I will typically do, especially in my young adult women that I see in clinic, I have the conversation about pregnancy in every single person. So somebody's 15, I'm like, what are you using for birth control or contraception? Nothing? This is a bad idea. And so we talk about why it's really important to plan for pregnancy and to prevent unwanted pregnancy. If we're doing that with every patient of childbearing age, then when we talk about the discussion for adding a statin in dyslipidemia or adding spironolactone in PCOS, for example, we've already had the baseline contraception pregnancy prevention discussion, and then adding on, this medicine is really good for X, Y, and Z, but there is that increased risk of teratogenicity in a fetus. And really bringing the patient along in that conversation, weighing the risks and the benefits, and choosing what's right for each individual patient, making sure that they are very aware of the risks that could be present. Another question in the chat: was there substratification for use of statins in those with diabetes based on A1C or time in range? Not that I saw. I do know, so that's actually not true. So I do know there was they were able to stratify and account for glycemic control in the larger studies, particularly those with type 1 diabetes, and they found that the lipid effects were independent of glycemic control in the patients with type 1 diabetes. Statins are good regardless of your A1C. They didn't look at time in range because we're using CGMs a lot more often now than they were when these studies were performed, especially the earlier kind of legacy studies, so they did not address time in range. All right, well, it is 5:04, and I certainly don't want to encroach on anyone's evening. When will the new pediatric guidelines come out? Dr. Thrasher, I'm enlisting you to form a committee, and I will be delighted to join you as a participant. If you elect to be the chair, we will make our own pediatric guidelines. Stay tuned for that. Thrasher and Folsom in 2022. Other than that, thank you guys so much for your attention today. I hope that you have a safe, warm, dry, non-frozen evening, and we will see you next week for our next Endocrine Grand Rounds.